A very good evening, ladies and gentlemen, and I would like to formally welcome everybody to LMHI 2021, the Global Colloquium. I'm your MC for the Hall 3. I'm Himay Lakhani. Namaste to all our foreign delegates as well. As our Indian custom, Namaste is a humble way to welcome. I would now like to invite and introduce our moderators for the session. We have Dr. Bharti Girdhar. Good evening, ma'am, and a warm welcome to you.
Good evening. Thank you, sir.
I would also like to invite and welcome Dr. Deepika Bhatnagar. Good evening, ma'am. A warm welcome to you as well.
Namaskar. Thank you so much, Mr. Himay.
Our session coordinators who are here with us, Gauri Chawla and Shrishti Sudan. And now I would like to hand over the virtual dais to our moderators, and they can introduce our speakers one by one, and the speakers can do the presentation. Our virtual dais handed over to our moderators. Thank you.
Thank you so much, Mr. Himay. Namaskar. A good evening and greetings to all. It has been our fortunate exposure to such a colossal, multilingual, multicultural, multinational digital homeopathic conference. Let me extend my warm welcome to all the dignitaries, and let me welcome our chairpersons, Dr. Todd A. Hoover, who is the Secretary of the Homeopathic Pharmacopoeia, United States. Dr. Todd? Good evening, sir.
Good evening.
Welcome to you.
It's good to be here. I'm looking forward to these talks. The subject matter sounds very interesting to me and very important topics.
We are also looking forward for that. Another chairperson is Dr. Bhupinder Sharma.
Good evening.
Good evening, sir. Dr. Bhupinder Sharma has been the National Vice President of LMHI for more than a decade, and he is an active member of LMHI Education. No doubt that he is called a walking encyclopedia of homeopathy in Ontario.
Thank you very much.
A very warm welcome to you.
Thank you.
Now I welcome our speakers, as this is the first day of the oral presentation of LMHI 2021. Now I'll be handing over the dais to my co-host, Dr. Bharti Girdhar. Dr. Bharti.
Good evening, everyone. It's my honor to invite our speakers for today's session. Let me invite Dr. Rosa Varanasi from India. The abstract title would be Homeopathic Medicine in the Integrative Management of Acute Encephalitis Syndrome. Outcome of result generated from 3 studies. Over to you, ma'am. Warm welcome.
Thank you so much for your kind invitation and an opportunity to present the results of the studies in this great platform today. So I'll be sharing my screen now. So is it visible?
Yes, ma'am. Visible.
So I'll be talking today regarding how a burdensome endemic disease, acute encephalitis syndrome, which is a very tedious and difficult condition to be treated, and how add-on homeopathy in an integrative care can help us to reduce mortality and morbidity.
Dr. Roja, sorry to interrupt. Can you just go on the presentation mode?
Yeah, I have done so. I have done so in the presentation mode.
That is the slideshow module, so we can see single slides. You can start the slideshow.
I have done the slideshow, but is it not visible to you? Is slideshow?
Okay, ma'am, you can go ahead now.
So what is acute encephalitis syndrome? So acute encephalitis syndrome is simply acute onset of fever and or new onset of seizures, clinical findings such as irritability, somnolence, abnormal behavior greater than seen with usual febrile illness. And this term has been coined for a surveillance purpose to just identify the cases of AES.
Dr. Roja, apologies, but you have not gone to the second slide. We can see the first slide, which is an introduction, and you are probably speaking about the second slide, which is acute encephalititis. Yeah, that's it. Thanks.
So shall I do like this only? Is it possible?
Whatever you are saying, we should be able to see it on screen. That would be more straight.
Is the full screen is visible?
Yes, it is. Thank you.
So the burden in India is large, and more than 6 states are affected, and the main state or the province affected is Uttar Pradesh. So this is the trend line of last decade, which shows there is still availability of cases, incidence of AES and JE in terms of death, which has been obtained from National Vector-Borne Disease Control Program, Government of India. So why it is challenging? Because JE vaccine is not produced in limited quantities. 3 doses of the vaccine provide immunity lasting a few years. Vaccine is not recommended as an outbreak. It is challenging to identify JE. There is no specific treatment, and the outbreaks are short-lived. And clinical management is supportive, and the acute phase is directed at maintaining fluid and electrolyte balance. So the main treatment purpose is add-on care, which includes treatment like managing fever, managing fever, IV fluid balance, correction of blood sugars, managing epilepsy, and also as soon as the patient is having signs of danger, they should be referred to tertiary care hospitals. So these are the various steps of management which is being provided by various core group meetings by different stalwarts, different experts who are managing JE. So what we have done is, when we went through the literature of homeopathy and especially synthesis repertory, we could identify there are 77 drugs outlined for brain encephalitis. And the prominent drugs are belladonna, aconite, granulia, camphora, cuprum, hyoscyamus, calibrom. So these all n number of drugs are there in homeopathy, which can be utilized based on symptomatology to manage a case of AES. So this is the study site where all studies were taken up at BRD Medical College and Hospital, Gorakhpur. And these are the situation, the kids. During the month of July to December, there is huge footfall of patients suffering from AES. The children, they suffer a lot, and they have to be admitted to the ICU, intensive care units of the hospital, with 3 to 4 children in a bed. Such is the load of the patients during these months of every year. So the objective of a study was to assess whether homeopathy as an oral treatment is effective along with institutional management protocol in reducing the mortality and morbidity. The inclusion criteria for all the studies which I'm going to present here today is age group of child 6 months to less than 18 years, having acute onset of fever, change in mental status, written informed consent. And exclusion criteria is simple febrile convulsions, any pre-existing illnesses, and if the guardian is not giving consent. So these are the assessment severity which we did through modified Glasgow Coma scale. It is a very validated scale. And this is the Glasgow outcome scale, which is again a Likert scale of 1 to 5. 1 is death and 5 is good recovery. Based on this, the outcomes were analyzed and presented today. So the first study we did in 2012 to 13, it is a hypothesis generating study. We did in a small sample size of 151 patients. The treatment arm consists of 121 and the control arm consists of 30 patients. Though there was some difference in the baseline, after adjusting for odds ratio, after adjusting for the Glasgow GCS, which is the severity assessment of the children, adjusting for that, it was observed that there is 30% reduction in the mortality when homeopathy is added. So the results showed 10% death in homeopathy group, added group, whereas it was 43% in only institutional management protocol. So the various medicines which were found to be quite effective were belladonna, stramonium, arsenic, helleborus. So following this study, we did the RCT, that is a randomized control trial, to infer the already existing small evidence through exploratory study. This RCT we could do again from the year 2013 to 2015, and here the sample size was little bit more than the earlier observational study, and the sample size was calculated based on the previous study. Total 648 children were randomized, and out of them only 612 children were analyzed. So in this, because the earlier part lacked any baseline differences, but here the baseline characteristics are comparable in both the groups. Here the outcome we could see there is also less odds or events of death, neurovegetative state in the homeopathic added group, and it is more in the placebo group, that is 14%, and here it is 29%. There is almost difference of 15% reduction when homeopathy is added. So following this study, and this study is published in Homeopathy Journal, which is a good journal internationally. And following this study, what we did is a real-time practice. In that real-time practice, we could enroll as many children as possible in the year 2016. Thereafter, we retrospectively collected control group data with a randomization, with a random numbers generated computer-based. And as per the computer-based random numbers, we did a listing as per the listing of AES available in that BRD college. From there, we could identify the control group as a comparator. Here also we could see, because it was not randomized, so there were some differences in the GCS scale. So what we did was, we did a adjustment for the GCS, and we could observe that the results which we found in RCT was similar in this group also. That was, the odds were 0.32, which favoring homeopathy as a add-on treatment to reduce mortality and morbidity, and to improve the morbidity of the patients when homeopathy is added. So these are the medicines which we can find: belladonna, stramonium, arsenic, helleborus, bryonia, opium, sulfur. There are various medicines which we could see top ranking in the treatment of AES. And this is the comparative summarized way of all the studies, where around 1300, more than 1000 patients were analyzed, and the recovery was quite more successful in the homeopathy treated arm, and the odds ratio are also very less, showing that the events of death is less when homeopathy is added. So these are one of the picture of a child before and after treatment. So conclusion, we can draw that homeopathy medicine has been found complementary to IMP in the management of AES. There was also 2 days early in resumption of oral feeding, and thus outcome can be helpful in translating under public health initiatives to reduce the mortality and morbidity burden of AES. However, more rigorous clinical studies and basic research experiments are also required. So what did Central Council do? Central Council for Research in Homeopathy, under collaborative research, they did a study to see the antiviral activity of belladonna on JE virus infection, which proved that belladonna helps in inhibition of microglial activation and inflammation, leading to neural cell survival. So in this way, some of the leads which we obtained through preclinical studies also give us a lead that homeopathic medicines are acting in a fundamental, showing the plausibility and also in the clinical effectiveness. This is another study which was done with Bose Institute, in vivo model, in vitro models, in the chick models. So all showing the efficacy of belladonna as a very good medicine in the management of AES. So this is the name of the team which I want to acknowledge, who helped us in conducting all the 3 studies. And this is our journal where we publish study results, and also we invite everyone to publish, submit their papers. Thank you so much.
Thank you so much, ma'am.
Hope I was audible and the presentation was clear.
Yes, ma'am. Thank you so much, ma'am, for your valuable presentation.
Shall I stop sharing the slide?
Yes, ma'am, you can
Yes,
stop
ma'am.
sharing,
Yes,
and
ma'am.
I request our moderator to please invite the next speaker or take up the questions if any from the audience? Thank you.
May I now request honorable chairpersons to input their ideas or their feedback?
It was a great presentation, Dr. Rosa.
Thank you, sir. Thank you so much.
Just a question, with the intervention of the homeopathic treatment, how did you coordinate with the allopathic doctors?
The allopathic doctors, they are there around the clock. They help us in follow-ups of the children who are admitted, and the senior research fellows who were there in the BRD Medical College for prescription, for each case taking, for consent process. So they were supported by the allopathic doctors who are around the clock in the BRD Medical College. In this way, they were guiding our senior research fellows for assessing the cases, for their progress, and also for assessing the GS, so that the study can be done in a very transparent and systematic manner.
Thank you, Dr. Rosa. Thank you.
So,
Thank you, sir, for your good suggestion.
Dr. Roja?
Yes.
Hi, this is Dr. Hoover. I appreciate the topic. It's very important. Obviously, a significant disease in India and other places around the world. And without acceptable conventional therapies, homeopathy certainly, it's a great opportunity for homeopathy to shine. I had several questions. One was, in your control groups, did you take a homeopathic case, or was it simply conventional care only versus homeopathy plus conventional care?
Yeah, the homeopathic case taking was done in both the cases for all children, and thereafter the indicated homeopathic medicine was prescribed.
And the prescribers had the full materia medica available to them, or?
Yes, and because they are postgraduates, they are SRFs, and they are trained homeopathic physicians. And before implementation of the study, conduct of the study, we did train them in each and every aspect of the protocol, so that they are well versed in documentation process, in screening process, and also in conduct of the study.
And finally, you employed blanks or placebos in the control group also, or?
Yeah, in the RCT, we used blank pills, placebos in the control group. But in the observation study, which we did the initial phases, there just we depended on the guardian, whether they're willing to take homeopathy, we gave them homeopathy. And those guardians who were not willing, they were kept as control. Likewise, in the retrospective study, because at that point of time, we had the result of RCT, and it was not ethical to debar the children from taking homeopathic medicines. So we randomly treated whoever the patient guardian consented for the taking homeopathic medicines. And later on, what we did is we traced the records from the line list of the hospital to see the controls we can acquire as per the random number generated according to the age groups. So in this way, on RCT, we gave the placebo, but in the other two cohort studies, we did not give placebo to the control group.
Good. It's important to mention this because there's an ongoing debate in homeopathic research whether the treatment effect of the interview is substantial, or if it's purely the medicine that's creating the difference between the two groups. So these kinds of things are very important to report in the literature. Thank you.
Thank you so much.
Thank you, sir and ma'am. Thank you, sir and ma'am, for your valuable feedback.
I'd like to request our moderator to please introduce the next speaker. Thank you.
Yes. Let me now invite Dr. Kusum S. Chand from India to present her observational study in homeopathy in antibiotic drug resistance and intolerance. Dice is yours, ma'am, please.
Good evening, Good evening, namaskar. I'm thankful to the organizers for giving me a chance to speak from this forum. As you said, my topic is my experience of homeopathy in antibiotic drug resistance and intolerance. Discovery of antibiotics in mid-20th century was a boon for advancement of medical science. Conventional medicine flourished by leaps and bounds. Overuse and misuse led to drug resistance and intolerance. With the result, it has become the bane of early 21st century. Results from World Health Organization survey carried out across 22 high and low income countries between March 2016 and July 2017 revealed antibiotic resistance to a number of serious bacterial infections. WHO spokesman Christian Lindmeier said the survey's findings raised many red flags among health professionals, admitting that it was one of the biggest threats to global public health. It leads to higher medical costs, prolonged hospital stay, and increased mortality. The world urgently needs to change the way it prescribes and uses antibiotics. A total reliance on only antibiotics has been an easy and one-sided approach. A change in behavior and recognizing the importance of self-defense mechanisms of living beings are important in combating antibiotic resistance. Without such change, it will remain a major threat even if new medicines are developed. An integrated approach to the treatment of chronic disease may be the answer. It may be between homeopathy as a regime and antibiotics. Patients with chronic disease and those with the recurrent complaints are usually multimorbid on multiple drugs. They have complex symptomatology. Mainstream medicine has no promising or permanent treatment. Repertorization of such cases showed some remedies were covering the presenting complaints, while others were covering the causative factors, and yet others were needed for an anti-miasmatic approach. In order to achieve the best possible reaction in a limited span of time, these remedies were studied in relationship to each other while working on TV project. A regime of medicines was formulated. This comprises generally of a morning medicine, one before lunch and dinner, and a weekly dose of anti-miasmatic medicine. It has been found that remedies used in a certain systematized manner simultaneously target multiple factors in the teleonomy of the patient, which is required for comprehensive treatment. This fulfills the holistic ideology of homeopathy. When used at the same point in time, they promote an all-round improvement of the case. It is as if lifting the system in one go and picking up all the loose ends so that the use of other conventional drugs for symptomatic relief is minimized. A project to explore the possibility of using homeopathy in the treatment of tuberculosis was undertaken by Government of Delhi, India. It was conducted in 2 phases. In phase 1, 142 category 2 failure cases were treated with add-on homeopathy. 94 cases had a follow-up of up to 1 year. It was found that homeopathy was useful and complementary to anti-tubercular antibiotics. In phase 2, randomized double-blind placebo-controlled clinical trial was conducted on 120 multi-drug resistant pulmonary TB patients confirmed by drug sensitivity test from 2003 to 2007. Statistically significant improvement was seen with add-on homeopathy in chest X-ray, weight gain, increase in hemoglobin, and reduction in ESR. In subgroup analysis of 81 culture-positive patients where homeopathy was started at the same time as antibiotics, cure rate was 11.4% more in homeopathy group of 44 patients as compared to placebo group of 37. In a parallel study on 50 cases of tubercular lymphadenopathy treated with only homeopathy, a homeopathic regime was formulated for the treatment of tuberculosis. It comprises of a patient-specific constitutional remedy which targets the individual response. Disease-specific nosode helps in providing immunity against the bacilli. Supportive medicine Silicea 6X as a general stimulant of leukocytic and fibroblastic activity. Now I'll present some case histories treated with homeopathic regime. Urinary tract infections are some of the most common bacterial infections affecting 150 million people each year worldwide. Antibiotics are the first line of treatment for most UTIs. People with underlying medical conditions or chronic UTIs are at the most risk for antibiotic resistance. A 45-year-old lady had recurrent episodes of E. coli culture positive UTI of 18 years duration with post-coital aggravation and burning. She had been on antibiotics, both prophylactic as well as curative, without any long-term benefit. When injectable antibiotics were prescribed, she came for homeopathy consultation on 10/10/2010. Her response to homeopathy regime of CPR 200C once in the evening, Cantharis 30C twice a day, and Staphysagrea 1M once a week for 2 weeks was effective. Post-coital burning recurred after 4 weeks of no medicine. Same treatment was repeated for 2 months. Since she had no recurrence and was asymptomatic, all treatment was again stopped. Acute episode recurred, which did not respond to previous homeopathic regime and was treated with antibiotics for 2 weeks. She again came and prophylactic homeopathy with changed regime was given. No relapse was observed for following 30 weeks. 74-year-old lady, wife of a homeopath, sought homeopathic treatment for culture-positive drug-resistant urinary tract infection on 31/2015. She had recurrent UTI for over 2 decades, along with diabetes, cystocele, and prolapsed uterus. These were also the maintaining cause of recurrence. UTI was treated with curative and prophylactic antibiotics and infrequent doses of indicated homeopathy. She consulted us for UTI with drug-resistant infection with Serratia marascens. After 6 months of regular homeopathic regime, drug resistance improved and frequency of infection decreased on 31/7/2015 without any antibiotics. After 18 months, on 23/6/2016, drug resistance shifted from multi-drug resistance to sensitive to all antibiotics. Diabetic profile improved and cystocele and prolapsed uterus were managed without any hospital admissions. This is the table of all the urine culture and drug sensitivity reports meticulously kept by the patient. Red color is for drug resistance and shades of green depict different grades of drug sensitivity. Dark green is sensitive in highest grade. Antibiotic sensitive pattern changed and shifted towards first-line drugs as compared to third-line drugs earlier, giving great relief to the patient. See, the first line shows all red and third row shows all green and various shades of various grades of drug sensitivity. This is the post-operative case of 75-year-old male with diabetes, enlarged prostate and chronic cystitis. He had fever, no appetite in spite of 2 antibiotics, drugs for pain, fever, and gastritis. The fever continued to rise even after addition of third antibiotic. Total leukocytic count was high at 22.9 thousand per cubic millimeter but blood and culture urine report was negative. On 7th day, MRI and CT scan revealed swelling of large intestine and possibility of intestinal TB was considered. We were contacted for homeopathic support. Homeopathic regime of Lycopodium naxvomica and Arsenicum album was given alternately every 2 hours. Next day, he slept more. On 3rd day, patient felt better, fever was less, he ate 3 meals, and TLC came down to 17.9 thousand. On 4th day, temperature was normal without antipyretics. TLC was 13,000. 5th day came down to 10,200. He was discharged 2 days later with a TLC of 9,200 without any more investigations. TB remains one of the world's deadliest infectious killers. Each day, nearly 4,000 lose their lives to TB and close to 28,000 people fall ill with this preventable and curable disease. The theme of World TB Day 2021, "The Clock is Ticking," conveys the sense that the world is running out of time to act on the commitments to end TB made by global leaders. This is the endometrial biopsy of 22-year-old case of primary infertility. Red dots are of Mycobacterium tuberculosis. She was treated with anti-tubercular treatment, which had to be withdrawn after 11 weeks due to intolerable drug effects. She was put on homeopathic regime. This is follow-up biopsy report. It was taken after 11 weeks of antibiotics, followed by 8 weeks of only homeopathy. There are no mycobacteria. This set me thinking that do we really have to give prolonged course of antibiotics? This is the colonoscopy report of a case of subacute intestinal obstruction from TB. ATT had to be withdrawn after 2 weeks due to drug intolerance. And you can see the ulcers in this picture. Follow-up colonoscopy after 4.5 months of only homeopathy. This proves there are no ulcers. The mucous membrane is absolutely healthy, and this proves no symptoms, no disease. This 26-year-old case of pulmonary TB with cervical adenopathy. She was treated with combined allopathy and homeopathy for 9 months. She had multiple adverse reactions causing drug intolerance. Add-on homeopathy helped her complete the course of ATT, and healing has been without fibrosis. Homeopathy is, my experience is that homeopathy is complementary to antibiotics. Used as regime leads to fast and perceptible recovery. Regime targets multiple factors in disease at the same time, is patient and disease specific, needs to be closely monitored. Regular homeopathic treatment reduces antibiotic use. Bridging the gap, expanding the horizons. Thank you.
Thank you, ma'am, for the presentation. And our moderators, we can take any questions.
Thank you, ma'am, for your wonderful case studies.
Thank you.
Let me invite our chairpersons for their suggestions.
Thank you, Dr. Kusum. Wonderful presentation
Thank you.
for your study. Did you find any limitations of homeopathy for the treatment of drug sensitivity during your study? When you say, no, this is not my case, this is a case of.
See, I had both the cases were drug resistant. They came
Yes.
after so many years.
Mm-hmm.
To see first case when she was put on injectable antibiotics, then she did not want to take those injections. She came, can homeopathy do something for her? And she had a wonderful result. I could trace her only till 30 weeks, and after that COVID happened and I did not go to the hospital, so I don't know what happened to her. And the third case was over 2 decades. She had, this is a very long case and it has been published in the journal Homeopathy. In fact, all cases except the post-operative case have been published. And see, she did very, very well with homeopathy. The only thing is we had to, in that case, we had to change the drugs very often. Every 15 days she was coming, and every 15 days we had to change the medicines according to change in symptoms. And progressively she was doing well, so I did not see any limitations. The limitation was of time. See, if it's a more difficult case, it takes more time. If it's an easier case, it takes less time. That's all.
And is the patient's cooperation with you A patient as well as
patient was doing well, so
Yeah.
all of them cooperated.
Thank you. Thank you very much. Thanks. That's my question.
Thank you, sir and ma'am, for your feedback. Let me now invite my co-host, Dr. Deepika Bhatnagar, take over the virtual dais.
Thank you, Dr. Bharti. I would like to invite our next speaker for this session, which is Dr. Sanjay Gupta and Dr. Jigyasa Bisaria, who will be presenting an observational study on effectiveness of joint Ayush homeopathic prophylactic program in 2019 for malaria containment in Madhya Pradesh. Welcome, Dr. Jigyasa and Dr. Sanjay.
Thank you. Very warm namaste to all of you. And I hope we are audible.
Yeah, you are audible. You are yet to share your screen, Dr. Jigyasa. Great.
So this is a simple summary of the work that we have done. And I would like to start with the title of our study. We were trying to measure the effectiveness of the joint Ayush homeopathy prophylactic program in the year 2019 for malaria containment in the state of Madhya Pradesh. Our state, Madhya Pradesh, is very, very prone to malaria as it has a very high forest cover. And a lot of districts are covered by water bodies as well. So that creates a more favorable environment for the vector-borne diseases. So it is very important to have a preventive management of malaria. So our state has a ministry which takes care of a specific department to take care of the issues which are related to malaria, which is the conventional healthcare routine. And along with that, this intervention was done in coordination with Ministry of Ayush, wherein the program was address this particular problem. The homeopathy was also brought into mainstream medicine as a preventive care and to reduce the incidences of malaria over a period of years. So the program started in the year 2016. And this was obviously driven by the evidence that is there in homeopathy literature, which suggested that homeopathy has been a very effective cure for containing the vector-borne diseases. So this is a summary of few studies wherein the efficiency of these drugs have been established. So as a part of the intervention which was done by the Ministry of Healthcare along with the Ministry of Ayush was to give this particular medicine named Malaria of 200. And it was distributed in 2 rounds in the peak months in the July to October period. And 3 doses were given in each round. Each of these doses were distributed over a week's interval. So the thing is, the people who channelized this whole project or the intervention were the accredited health workers, the ASHA, and the multipurpose workers and the Anganwadi workers. And with this particular intervention, almost like a large number of villages, 23 to be precise, villages were brought into the program coverage, and preventive medicine was administered to almost 82% of our population, 82% of the target population who were at a very high risk of malaria. Of course, the study area have been identified due to recorded cases of very high incidences of malaria by the health department. And with the help of this, once this particular program was brought into picture, the data was collected on a regular basis by the ministry. We didn't have any specific funds to administer or put up any research into this particular project, but this was supported by both the ministries working hand in hand together. And over a period of years, all the 2 years data was compared, and an annual analysis of the cases or the outcome of this project were being documented. So these are a few reports that came out over a regular period of intervals, and compiling the outcomes or the incidences which were tracked by the live data collection, which was done by the Ministry of Health of Madhya Pradesh and along with the Ayush. And Dr. Sanjay was the nodal officer. He was the one who was collecting all the data and was proactively chasing people and getting all the authorized data in one place. So with the help of with such a huge volume of data available with us, which was collected through authorized sources, we come up with this particular study with the two objectives. We wanted to actually quantify the program impact, which we could attribute to the interventions of Ayush. So we wanted to see, like, it's obvious, like, we referred to various literature which are related to program impact assessment. And a very recent literature, and as suggested by World Bank and organizations like WHO, the most suggested method to be used for program impact evaluation is the double difference method. That means this method is all about quantitatively assessing our cases, or the ones that are affected by the program, versus the control population, which is not affected or is being put on a control group wherein the interventions are not administered. So we actually trace all these cases over a period of a timeline, and then use the double difference scheme to quantify the actual program impact, which could be attributed to a single intervention. So this is a statistically sound method and has been recently found focus due to various reports by World Bank. And the technique is known as result framework as well. And in 2019, this program covered almost 26 lakh people, and the program was spread across 171 blocks, which fall under the 38 districts in the state of Madhya Pradesh. And the average penetration of this intervention was almost 82% of the target population, which was at a risk of this particular disease. So once we collected all these data, we could generate a time series of incidences of malaria over a period between 2016 to 2019. So both the programs, and we could find a suitably located control group wherein the program was jointly being done, and we could identify cases wherein the cases were the program where the program was co-done by both the ministries, versus when the program was done only by the Ministry of Health. So we could suitably attribute or create cases and villages wherein we could segregate people by those cases who are getting both kinds of medication, preventive healthcare plus the Ministry of Healthcare's interventions, versus the ones that were getting only the regular interventions which are done conventionally. So then we tried to model this series of incidences, and then we divided these incidences between two periods. One is the January to June period, and the other was the July to December period. So while the interventions were done in the October to July to October timeframe, this served as a control population for us. So program coverage was gradually increased. There were some villages which were covered in 2016. There were some which were brought into the picture in 2017. So the program was continuous and discontinuous at various stages at various spatial locations. But then the whole data was aggregated in a way that we could generate a regression model, wherein a regression model with an accuracy of 94.53 F value, a P value which is very significant, and an R square which accounted for 0.994. These incidences were modeled, and we could see that the model was very, very close to what would have been the incidences if only the Ministry of Healthcare or the malaria department was put into place. So we recorded that over this particular Jan to June period, there was a decline of almost 458 cases annually over this particular 6 months period, which we could model with a very high accuracy. But when we took the actual numbers for the year 2019, we found that there was a deviation of almost 31 cases. That means, as per the model, there could have been only 359 incidences of malaria, but the actual numbers that were reported on ground were 390. So this absolute deviation from the model versus the actual number of cases, we could attribute it to the absence of the additional intervention by Ayush. So now we have this particular case wherein we again remodeled the data or the incidences over a period of 3 years, and we could model and generate a model which again a very high accuracy of 0.99. So the predicted number of cases as per the model were almost 2,110 in the July to December timeframe. With this regular interventions, we could observe that the annual decline was, with the interventions and proactive management, the annual decline was about 1,031 cases. But when we actually looked at the numbers of 2019, we found that the actual number of incidences were greatly reduced to 972, which we could comfortably, using double difference scheme, quantify as the additional intervention or the additional decline in the incidences, which were brought in due to the joint interventions by Ayush. So if I compute it by the mechanism wherein I monitor my cases over baseline and end line of the project, and I also monitor my control group over the baseline and the end line, I am able to quantify the change as the actual change which has been which has been brought in by the Ministry of Ayush would be a decline of almost 1161 cases using the double difference scheme, which is the recommended methodology. To try to model in similar way, we tried to look at the program coverage, and we looked at the data of how the coverage was increasing and attributing to a change, which is increasing the number of villages which fall under the bracket of 0, 1, or even 2 incidences of malaria. So that's the whole target, wherein we want to increase that bucket of villages wherein there are very, very less or near negligible cases, incidences reported of malaria. So when we generated this particular model, again, this model was a linear regression equation with a p-value of 0.05 and an R-square of 95. That means almost with 95% accuracy, we could predict the number of villages which are falling in the 0, 1, 2 case bucket. And once we actually looked at the model, and as per the predicted model, the total villages which were supposed to be in this particular bracket were 1,068. But if we saw the actual numbers on the ground, we found that there were 1,321 villages which came into this cluster of almost 0 incidences over a period of 4 years. So this we could attribute to the interventions by Ayush, that as more and more villages, target villages, were covered under the preventive management with malaria, there were more villages that were coming in this particular bracket. And we could attribute this change, or we could attribute this positive deviation of falling in the 0, 1, 2 clusters of these villages. Due to Ministry of Ayush, we can comfortably say that we have 253 additional villages now which fall in this bracket. So this is a summary of our findings. We noted that the program coverage, though it was continuous and discontinuous, till the year 4th year, we found a lot of villages, that is almost 23 villages came under the joint intervention program by the Ministry of Ayush. And the program coverage, and out of all the analysis of the permutations and combinations and doing various comparative assessments, we found that as wherever the joint Ayush-based programs were done for preventing malaria using homeopathy, the results were extremely good. And in most of the cases, there were reduced incidences of malaria with the joint program. So this is the actual program impact that we have computed through the double difference scheme. And we could attribute this change of additional decline in the cases of 1,161 to the interventions by the Ministry of Ayush. And further, to summarize, we have 253 more villages because of this joint intervention program into the 0, 1, 2, 3 case buckets. So our overall findings suggest that this co-management by Ministry of Ayush and the conventional Ministry of Healthcare is a very, very cost-effective and useful way to contain malaria. Thank you.
Wonderful presentation, Dr. Jigyasa. I would now request Dr. Todd to ask some questions if we have.
Sure.
Dr. Jigyasa, you may just put off your slide. Yeah.
So first off, wonderful study, well executed, and using a lot of the technology that is not super expensive, which is nice. I just had one real question. The study is predicated upon the notion that there is only a linear change in the conventional approach. So you have 4 years of data seeing a linear change. Is that modeling demonstrated in other arenas? So if we're looking at different regions, do we always see a linear change in when the conventional approach is conducted, or is there a logarithmic change that occurs over time at the 3 or 4 year point, because if that's the case, then all of a sudden your basis for assessment changes.
So we can do an assessment wherein, like, if we get in control case points wherein the interventions is continuously done for many years, and we are able to model only those scenarios or those villages continuously, and if we are able to see linear to logarithmic transformation in the decline of the cases, maybe that kind of model we can build. But with the linear modeling, in the present scenario or the present availability of our data, we could see a fairly reasonable, accurate model. So the data corroborated well with what we were predicting with our model.
I guess what I'm asking is, are there other states in India where malaria has high prevalence and it shows a similar linear progression? In cases, that would be further evidence that there's no confounders there, especially for that particular year.
Definitely, sir. If such a program is implemented in cases wherein the incidences are very, very high, we might as well, observe a logarithmic change in the decline. If similar data collection plan and strategy is put in place. And
No, my specific question is: are you aware of any data from other states that looked at the same time period to see if there was a linear change?
So presently, as far as our knowledge goes, on record, no such data or no such integrative activity at this public health level has been put by any of the state of country, except Madhya Pradesh. In Madhya Pradesh, we have been doing since 2016 regularly, and almost 20 lakh plus population is covered every year. And we have reviewed the data of 3 years, 2016, 17, and 2019. Whereas for the year 2018-20, we missed the data because of local reasons like election in the state and because of pandemic into 2020. Regarding 2021, since I'm not the nodal officer and I don't know whether such publication will come up. If it comes up, we will like to share with the authorities.
Yeah, I think the data would be very, skewed a bit because of the COVID issues, so it'd be hard to make much judgment. But I think wonderful work.
And as I want to focus, sir, since it was non-funded activity, research activity, the mass public health activity with the routine funds, minimal funds of Ayush was conducted, paper was generated, and we expect in future to further go into details point-wise with many more confounding factors if we receive the funds. We are putting attempts for it. Thank you.
Very good. Very good.
Thank you, Dr. Todd. Thank you, Dr. Sanjay. I would now request Dr. Bhupinder if he has some questions to ask from Dr. Jigyasa and Dr. Sanjay.
Thanks. Great study done. Just to curious to know about the common prophylactic homeopathic drugs used in the study.
Single drug was used, sir. Malaria of 200 for her in the study.
Good. Very good. Very good. So the results were validated, or it is still to be validated?
Pardon? I could not understand.
The results have been validated or not?
Of course.
When you single medicine. Okay. Good. Very good. So doing a great job. Thank you.
Thank you, sir.
Thank you, Dr. Bhupinder. I have like 1 or 2 questions to ask from you people, right? First is, what was the frequency of repetition of this medicine, malaria? Yeah, you said there were 2 rounds done from July to October. So what was the frequency?
The frequency was, actually in 2016, the schedule fixed by the state government authority was for 6 doses in 2 rounds. 1 round computing of 3 doses. And in between 2 rounds, there was a gap of 8 weeks. But in subsequent years, it was changed to 6 weeks. So we had first set of round in the month of July, then second set of round in August, September, last of August to September. Besides that, the standard practice was 1 week interval, 1 dose. But sometimes there were rains. And in rural population, they were unable to cover because of,
I understand.
So that flexibility was there. Then they put the dose on 8th day, but then second dose was on time.
All
That
right.
means it will. So we try to maintain the schedule unless and until it is postponed because of some local reasons. And we
Alright.
had this history in, if I'm not wrong, if we total it for all the 5 years, it was not more than 25 villages. Otherwise, the time schedule was maintained by the ground level workers.
That's nice. And did you cover the infants in this, or only the adult population was taken care of?
No, whole population. See, actually, what was happened is the malaria department, which is the authority department by the state government, gave us the list of villages with high incidence of malaria
All
at
right.
high risk. And assuming the statistics of 2011 census and somewhere at district level, the population figure which were given were assumed to be targeted population. And
All
when
right.
we gave the medicine and we totaled it, we found it was close to 82% of the
Okay.
target population. And this 82% was almost 8% of the state population. And our state
Okay.
population was 7 crore approximate. So you can understand to what extent. And
You have
secondly,
covered.
the districts were and blocks were spread throughout the geographical area of the state. So this is encouraging. We are getting data from every pocket of the state.
That's nice. Then you had good results also. Just last one more question. Why did you not go for China as given the literature? And
See,
why?
I got it. There are, I think there may be many more drugs also. But
Yeah,
what has
just
happened is I tell you we are bound with the state government program. Since
all
state
right.
government make it a policy, so we had to go with that. Besides
right.
that, I would also like to thank CCRH, Dr. Manchanda, when he was Director General in the office. He visited our state government and he had the talk with the Principal Secretary and ACS of Health Department and Ayush Department. And many more details were discussed for this.
That's nice. That's nice. That was lovely, Dr. Sanjay, discussing it with you, and all the best for your future projects.
Thank you
so much. Now I may proceed to call upon the next speaker, who is Dr. Professor E.S. Rajendran from India. He is going to present an article on antibiotics of with the abstract ID 24.
Hello. Can you hear me now?
Yes, sir, loud and clear. You can go ahead, please.
Okay. So thank you everyone for the nice evening. And it's a wonderful day for LMHI. And we are online. We were always offline in all the conferences earlier. Thank you, one and all. So this antibiotic is a failed legacy. That's what I'm going to speak about today. So the story of microbiology we all know well. It started with the great scientists Louis Pasteur and Robert Koch. And in 1861, Pasteur published his germ theory. And further, in the later years, both of them, Robert Koch and Louis Pasteur, published many things related to microbiology. And the Koch's postulates gave the foundation for bacteriology in the later years, around 1890. So, but that was the basic understanding in the world of medicine as a new evolving therapy that is bacteria and the antibacterial agents. But the first breakthrough discovery came in 1928 by Alexander Fleming. He discovered penicillin, as we all know the story very well. And around 16 years, it went on like that. And when the Second World War was on its peak level, the industrial production of penicillin began in 1944 by Pfizer from USA. And we know Pfizer very well, which is one of the most renowned pharma company in the world. So use of penicillin in the Second World War revolutionized the world of medicine. And we can say that penicillin is the foundation on which today's modern medicine and medical industry was built. But when the antibiotics was extensively used, what we observed is, as a biological organism, bacteria started developing resistance by using instructions provided by the DNA of bacteria. And it developed many mechanisms to make antibiotics ineffective or destroy them by using enzymes, proteins, breakthrough antibiotics, etc. So as of today, after 70 years of extensive use of antibiotics, we are in the 5th and 6th generation of antibiotics in use. And the latest statistics shown by WHO in 2018, they said that 2000 to 2015, the defined daily dose, DDD, of antibiotics has increased from 21.1 billion to 34.8 billion. That is a 65% increase in the last 15 years from 2000 to 2015. And it is projected to be around 84 billion DDDs by 2030. This is where we are standing today. So morbidity and mortality due to antibiotics. Antibiotics is a significant cause of morbidity and mortality. And yearly antibiotic resistant infection is around 2.8 million in the US and the death around 35,000. And this is because of, it's driven by the antibiotic consumption growing globally, and it's a global health threat as per WHO. So why we are getting into this? Usually the type of antibiotics used we can see primarily for bacterial infections. It's a discovery meant for bacterial infections. But later we started using in every viral infections as an additive drug to reduce the possibilities of bacterial complications. More than that, non-therapeutic use of antibiotics became very rampant, especially in animal husbandry, beekeeping, fish farming, ethanol production, horticulture, even in toothpaste. Most of the toothpaste which we saw prevents infection has an amount of antibiotics in it. And it does food preservation everywhere. So all these lead to the selection and spread of antibiotic resistant bacteria around the world. So the study shows that non-therapeutic antibiotic use has environmental antibiotic resistant gene legacy. So the major culprit of antibiotic resistance is coming from non-therapeutic use of antibiotics. Actually, the antibiotics is one of the greatest discovery in human history of medicine, but it is one of the most misused drug in human history, and it may go to be ineffective in the years to come. And now the scientific community is finding building up more and more advanced antibiotics seems to be an impossible task. So why this situation has created? I will say fundamentally it is one of the pillar of the problem is scientific community itself, because the scientific community conveniently ignored the role of innate immunogenetic system in infections. And the rational use of antibiotics everywhere to bypass the natural mechanism of immunity building systematically degraded the human immune system in the last 70 years. And the second culprit in this model is the capitalist economic model, which finds antibiotics as the biggest wealth creating object in human history. Every company which started producing antibiotics in 1940s during the Second World War become trillion-dollar companies by now. And this industry created more and more wealth, and they created more and more demand for antibiotics by diversifying the antibiotics from medical use, from bacterial use to other non-medical industrial use. So that is a manipulation in the history of medical practice, in the medical research, and even it inculcated into the medical textbooks. So creating more demand, diversifying the use of antibiotics in non-therapeutic use, the outcome is the perilous situation today we are facing, that is universal resistance of antibiotics. And the humanity is edging towards a dead end in treating bacterial infections in the years to come. And that is what the today's projection in the field of science. So the mechanism of antibiotic resistance involves the transfer of bacterial genes between humans, animals, and the environment. The selection pressure has promoted the mobilization of horizontal transfer of a large range of antibiotic resistance ARGs to many bacterial species, particularly those creating infections. So in this current situation, what we can expect? We have to promote the immunity boosting medications around the world, like homeopathy, Ayurveda, and other traditional herbal medicines. They naturally improve the immunity of the host. And restrict the antibiotics used only for essential therapeutic use. Prevent the use of industrial non-therapeutic use of antibiotics. And eventually, I feel the science should discard the concept of antibiotics, because It's an unsuitable idea in natural biological system and biological balance. And this is very important because we are heading to a crash down in the health industry because the health industry has taken a route of easy method of killing the bacteria to prevent the diseases. And we are landed in a stage where we have failed to do so anymore. So thank you, everyone. Thank you for the time and thank you for the patience.
Thank you, Dr. Rajendra. I would now request Dr. Todd to ask any questions if we may have.
Dr. Rajendra, you can meanwhile stop sharing the screen. Thank you.
Thank you.
So thank you. Excellent. Issue is obviously of vast importance right now. The conversation you've described actually goes back to ancient Egypt with two individuals, the Ebbers and the Cutters, who described the reductionistic approach, which is the antibiotic use, versus the holistic approach. And it's been going on ever since. And Hahnemann was right in the middle of that conversation. I'm wondering if you have any opinions on the current shift in conventional medical approach to monoclonal antibody use, specifically with the targeting of immune system regulation that's going on mostly in cancer research where they use cancer vaccine therapies, but certainly is likely to shift to the bacterial infections in the future, where people will start abandoning antibiotics in favor of monoclonal antibody use to provoke an immune response. Any thoughts on that?
So that's really a great possibility which you are told, Dr. Hoover, because the science is modifying itself and realizing that this mode of treatment of eliminating an organism against a disease is not going to work for a long time. And here what we observe is the systems of medicine which were discarded after the discovery of antibiotics, especially homeopathy was completely discarded in the US and Europe after the discovery of antibiotics and Second World War. And it has a great role to play. Just now we heard the papers which published based on the treatment of malaria and on the treatment of tuberculosis, where the resistant bacteria were better controlled by homeopathic medicines. And definitely we feel that homeopathy is making immunomodulation in a better way. So use of antibiotics into a drug of emergency or an important drug to be used discreetly is the most important thing, rather than using it as a day-to-day practice for each and every disease. And supplementing therapies like homeopathy will definitely boost the situation where the use of antibiotics can be drastically reduced around the world.
Great. Thank you.
Thank you. Thank you, sir.
Thank you, Dr. Rajendra. Dr. Ravinder, sir, do you have any question to ask him?
No, I'm okay. I'm fine with that. Yeah, so we gave a small time to you. We wanted to hear more from you. Maybe next time. Thank you.
Thank you. Thank you, Dr. Sharma.
Thank you so much, Dr. Ranjan. All the best. You have picked up a very valid topic, need of the hour. Thank you so much. I would like to now call upon my co-host, Dr. Bharti, to please take up the dais.
At the end of this session, I would like to thank all of you, our speakers, for their miraculous case results, our valuable feedback from our chairpersons, all of our participants, delegates, our coordinator, moderator, and team managers, of course. Thank you. We learned a lot from this session. Namaste. Let us now switch over to our next session, Innovation in Pharmaceuticals. I invite Dr. Deepika to call upon the next speakers.
Thank you, Dr. Bharti. I would like to call upon Dr. Suman Chakravarti for his presentation.
Dr. Deepika, sorry to interrupt. If all the speakers are there, can we have a group photo if possible?
Yes, Dr. Roja. It is Dr. Roja, if I'm not wrong, right?
Yeah.
Yeah, Dr. Roja, I don't have any question answers from the audience side. If you want, you may leave.
And Dr. Roja, the photographs will be done at the end of the session.
Madam, may I audible to you?
Yes, Dr. Suman Chakraborty, you are audible loud and clear.
May I proceed?
Dr. Deepika, you need to unmute yourself.
Sorry. Dr. Suman, let me just invite you and give me the abstract ID before you start sharing. Dr. Suman Chakraborty will be presenting the abstract on new drug development, which is a phytochemical analysis of Strychnos potatorum seed and double-blind placebo-controlled human pathogenic trail of Strychnos potatorum 6, a new drug source in homeopathy. His abstract ID is 677. I welcome you, Dr. Suman.
Welcome, madam. Good evening to all sir and madams.
You can
May I-
share your screen, sir.
Okay, madam. May I proceed?
Please, sir.
Okay. Slide, please.
I also request Dr. Maria if you can be ready with the presentation as we are going to be up next. Dr. Suman, everything okay with you? Technical
Yes, sir. I am ready.
Please share your screen, sir.
Okay.
You have 7 minutes of your presentation time, and
Yes.
I think we can see your screen. You can start
Yes, madam.
and you can proceed, sir.
Okay, madam.
Yes, we can see the screen, sir.
So I am visible and audible to you, madam.
Both, sir. Please go ahead.
Okay, madam. Good evening, sir and madam. This is an underlined project, phytochemical analysis of Strychnos potatorum seed and double-blind placebo-controlled human pathogenetic trial of Strychnos potatorum seeds. A6, a new drug source in homeopathy. This work was guided by Dr. Rajat Chattopadhyay, Dr. Sangita Saha, and Shormishta Gupta Madam, Kaushik Bhatt sir, and I am fellow Dr. Suman Chakraborty. Why we choose the Strychnos potatorum? Loganiaceae family of the plant contains 13 genera and near about 400 species as per taxonomy. Plants mostly are topical and medicinal, hence it becomes one largest family of the medicinal plant. Further literature review shows that most of the medicinal plants of Loganiaceae family belong to the genus Strychnos. Hence, we narrow our focus on genus Strychnosale. Our further field and herbarium study with research help from Botanical Survey of India, Shipur on genus Strychnosale shows most of the Strychnos species exotic and only 12 species are indigenous. Among the 12 species, only 2 species, Nux vomica and Strychnos potatorum, used as medicinal source in Ayush system. Nux vomica is used in all system of Ayush, but Strychnos potatorum is used all system except homeopathy. Hence, we took the Strychnos potatorum as our new medicinal source. It is the description of the plant Strychnos potatorum and abundantly distributed throughout the India, including Bengal. Fruit, you use the seed of the Strychnos potatorum. It is the seed property which is anti-diabetic, antipyretic, hepatoprotective, and anti-ulcerative property. One of the main component of the Strychnos potatorum is diaboline, which is an potent hypotensive agent. Now, the objective of our study to prepare a new homeopathic drug named Strychnos potatorum from the seed of Strychnos potatorum by the homeopathic principle, and to acquire the knowledge of the Strychnos potatorum through the homeopathic process of drug proving. Now, the outline of our experiment: procurement of the SP seed, identification and authentication of the seed, then the ethanolic extraction of the seed, preparation of the mother tincture, standardization and the chemical characterization, ethanolic extract, preparation of the 6H potency as per HPI guideline, and then the HPT. This is the morphological character of the Strychnos potatorum seed. Both macroscopical and microscopical criteria are present. This is the seed. This is the diameter and thickness of some seeds. Those are the control seed. And this is the microscopical presentation of the seed of Strychnos potatorum. This is the microscopical views. And this is the authentication from the BSI Sipur of the Strychnos potatorum seed. And these are the whole seed, first crushed into powder, then it will extraction for 21 days within the 30%, 50%, 60%, 70%, 80% ethanolic concentration, then filtered, press, and volume makeup was done. These are the concentration of ethanolic extraction, and these are the character of the filtrate: 30% non-turbid transparent, 50% transparent, 60% turbid, 70% and 80%. Among of the, then we go for measurement of the total dissolved solid. Among the total dissolved solid, we got the 70% is the most transparent, with getting the majority of 0.766 of the total percentage of the TDS, but 50%, 60% are turbid. As we know, the mother tincture must be filtered clear, so you use the 70% of the methanolic extraction because it is the highest TDS among 70% and 80% of transparent fluid. Now, these are the standardization of the strychnos poetarum mother tincture. These are the component of ethanolic extract with several component. Alkaloid is present, and we find the TLC study that is diabolin is present, and this is the UVV spectrophotometry. And preparation of the strychnos poetarum 6CH with the following the HPI rule. Now double-blind placebo-controlled RCT, following the CCRH guideline. It is our CTRI registration number is presenting in the slide. Volunteer enrollment first, then screening with apparent healthy prover, selection of inclusion and exclusion criteria following the HPI guideline. These are the schematic outline how HPT is going on. Now the short snap study, Veram, strychnos poetarum 6, comparator arm placebo, study design, double-blind placebo control, total prover 37, apparent healthy prover 30, male prover 21, female prover 9, allocation ratio 1:1, prover without symptom 5, prover need medicinal intervention, drug proving unable to continue 2, medicinal code and placebo code are mentioned. These are the proving system at a glance, and we call these are the proving system at a glance. Next, we go for the symptom conglomeration according to the Kent repertory schema of chapter head to foot. These are the all thing. Next, these are the symptom of skin rashes coming out from the drug proving. Now the conclusion. The experiment showed the scope and efficacy of strychnos new drug source in homeopathy. And this is the most predominant symptom of the drug proving is the breathing distress coming out in 2 of the prover, constipation present in 2 prover, and eruption and rash present in many of the provers. The experiment showed the scope and efficacy of strychnos poetarum as new drug source in homeopathy successfully. The result of macroscopical and microscopical study of experimental seed corroborated with the morphological character of strychnos poetarum seed, thus proved the authenticity of the seed. Strychnos poetarum mother tincture prepared with 70% aqueous ethanolic solution. TLC study 70% of ethanolic extract showed diabolin as a major active principle, and potency was prepared from the mother tincture. HPT was done with 6CH potency, and this breathlessness, constipation, and eruption is the most predominant symptom of the HPT. And these are the future prospect. We have a future prospect that least work has been done on the strychnos plan. So far, a great scope remains to utilize the plan. The multicentric study of the drug is needed for more and more outcoming of the symptom in combating with the viral disease. Isolation of the active principle, prepare drug from them. Future HPT can be done to find out the genus, species, and family symptom. The vitro study of the drug pathogenesis is very much essential with the cell signaling procedure, which help the probable most scientific model about homeopathic drug pathogenesis. And also a note we find that the seed has water purification properties, so a future prospect will be needed in relation with the public health with waterborne disease. This is the acknowledgement, and thank you.
Thank you, Dr. Suman. This abstract has definitely been a distinct and unique of its own kind, right? I would like to request Dr. Todd now to ask any questions from Dr. Suman.
Yes, madam.
So,
Suman, you may just take off your slide from the screen.
Okay.
so thank you. I actually spend quite a bit of time evaluating HPTs as part of the pharmacopoeia. A couple questions. One, was there any toxicology available, any history of toxic exposures to this compound in the literature?
Sir, when we make our documentation in the first it is our 3 years project. At first year, we have made a documentation on the Loganiaceae plant family. We find out there is more and more plants are present in Loganiaceae family, which made the Loganiaceae family as the greatest medicinal family. When we got for more and more documentation, then we find most of the medicinal plants of the Loganiaceae family belonging to the strychnose. And when we go for the strychnose, then we find the only 12 indigenous strychnose are present in our area. And we more than focus our area to the indigenous strychnose. And in indigenous strychnose, we find Strychnos potatorum is least toxicological but highly curative value in traditional system of medicine, in Ayurveda, in Siddha, in Unani, except homeopathy. It has anti-tubercular effect, antimicrobial effect, and those have papers on their action.
But in the literature, were there any cases of overdosing, overexposure, or toxicology from the Strychnos potatorum?
Sir, we have found not so such of toxicological paper of Strychnos potatorum. Rather than we have found the seed of the Strychnos potatorum has water purification property. In our research project, we have borrowed that idea in future prospect that we can use it as a water purifier in relation with waterborne disease.
Right. Okay. And any thoughts on why some of the provers didn't have any symptoms, any response?
Yes, sir. Please repeat, sir.
5 of your provers had no response to the medicine.
Yes.
Any thoughts on that?
Sir, as per homeopathic point of view, every person has his own susceptibility to react. If it is our assume that 6 potency was unable to react their vitality or to react them to react with the symptom of medicine, they require maybe high potency.
Great. Okay, thank you.
Thank you, sir.
Thank you, Dr. Todd. Thank you, Dr. Suman. I would now request Dr. Bhupinder to go ahead with his questions.
Yes, just one question for you.
Yes, sir.
The provers got very few symptoms like rash,
yes, sir,
stress, and constipation.
Yes.
So, what was the composition? I mean, there were 9 or how many provers were there total?
Sir, we have done it with 30 provers.
30 provers.
Because it is our 3 years project. First year, we have made the documentation to choose the Strychnos potatorum as our selective plant source. Second was preparation. And third year was for HPT. As we did it in a single institution, that we got about 37 volunteers. From there, we got the 30 apparent healthy provers. And upon 30 apparent healthy provers, we proceeded our proving. And it is our future claim that we want to do it in multicentric study so that more and more symptom can be came out and we can make a good statistical validation of that drug.
Yeah. Okay. All right. Thank you. Thank you very much. Thanks.
Thank you.
Thank you, Dr. Bhupinder. Thank you, Dr. Suman, for your presentation. It was indeed very nice. Thank you. Now, may I request my co-host, Dr. Bhati, to take over the dais?
Thank you, ma'am. I may now request Dr. Maria Divya from India to present her nanoparticle study. Over to you, ma'am.
Ma'am, are you able to see my slide?
Yes, ma'am. It's clear.
Okay. Greetings of the day. I, Dr. Maria Divya, here will present a project on preparation, characterization from skin of sardine picadrus and crustacean shell of crab and prawn with impregnated biosynthesized nanoparticles using Cantharis mother tincture and Cantharis 30 for the treatment of 2nd and 3rd degree burns, a preclinical study. We all know the treatment of burns, especially the 2nd and 3rd degree burns, are a little difficult. And we know that Cantharis mother tincture or Cantharis remedy as such is very beneficial in the treatment of burns. So we wanted to work on this aspect where application or external application of Cantharis as a form of an ointment or directly as a tincture, it's very difficult as it causes severe pain. And so we wanted to convert it to a very easy form of administration where we derived the concept from tilapia skin of basal physicians and secondary skin. From that, we have
projected onto this particular project. In this project, myself have worked with Dr. Bhagyalakshmi and Dr. Janita Emima Pakyam of Alva's institution. This particular project was funded by Rajiv Gandhi University of Health Sciences, Bangalore, under the Faculty Research Grant of 2019 and 20. The aim of this particular study is, first, we wanted to prepare the marine-derived collagen peptide from the skin of sardine plicadris and crustacean shell, and then we wanted to incorporate the mother tincture and Cantharis 30 direct form, as well as the biosynthesized silver nanoparticles of the same into the peptide sheets, and we wanted to construct a sheet, and that sheet was subjected into in vitro and in vivo evaluation for the action. In vitro, we have studied using keratinocytes crash test, and in vivo, we have studied using creating artificial burns in albino rats. In this particular project, the first step what we did was we prepared the sheet. For that, we have taken the sardine plicadris and crustacean shell, and we have chemically processed it to prepare chitin. And after preparing chitin using deacetylation process, we have prepared chitosan, and this chitosan was then simultaneously we have prepared Cantharis 30 and Cantharis mother tincture, and we have subjected it with the reduction reaction of silver nitrate solution so as to prepare the biosynthesized silver nanoparticles of Cantharis mother tincture and 30, and we incorporated these both together to form a sheet. And that sheet we have prepared in 6 different forms. One is a plain sheet, and the MCP2 belongs to the plain sheet with silver nitrate solution, and third group is MCP marine-derived collagen peptide with Cantharis mother tincture, and the fourth group is marine-derived collagen peptide with silver nitrate biosynthesized Cantharis mother tincture, and fifth group was with Cantharis 30, and sixth group was with biosynthesized silver nanoparticles of Cantharis 30. So this sheet, these 6 sets of sheets are subjected to keratinocytes crash test. Before going into the keratinocytes crash test, we use the cytotoxicity studies to understand which dilution is better, and then we went for keratinocytes crash test. Another way, what we did was in vivo study, we did it on animals where we artificially created burns by using the molten wax, and then we demarcated the area margin, and we have gradually progressed the improvement by using the medicines in different groups. So these are the ways we have studied it, and the results what we obtained was in physical and phytochemical studies. We didn't have any significant difference between these groups, but in case of zeta potential, we observed a significant difference in case of Cantharis 30, because the Cantharis mother tincture and biosynthesized silver nanoparticles of Cantharis mother tincture as well as biosynthesized silver nanoparticles of Cantharis 30 was significantly stable. But in case of Cantharis 30 itself, it was an unstable component. That's what we noticed. And antimicrobial action, we all know the nosocomial infections in case of burns is a very major issue that we come across during the treatment. So addressing that, we understood that biosynthesized silver nanoparticles of both mother tincture as well as Cantharis 30 has shown significant better antimicrobial action compared to the other groups in control group. And here we have also studied about the antioxidant property, where we have understood that Cantharis 30 and its biosynthesized form is able to have a scavenger action of about 90.90%. And when we subjected it to particle size analysis using SIM and TEM, scanning electron microscopy and transmission electron microscopy, we found that the particles are majorly light between 50 to 100 nanometers, except for C4. C4 is the biosynthesized silver nanoparticles of Cantharis 30. Except for that, the remaining all light between this range. So predominantly, the mother tincture and 30 was in 500 range, and the Cantharis mother tincture biosynthesized nanoparticles was in 100 range. But in case of C4, what we noticed was the particles was very smaller in size. It's almost less than 10 nanometers. This is the SEM image that we obtained, and this is a TEM image. In the TEM image C1 and C2, you can see the particles are spherical in shape, and in case of C3 and C4, the particles are rod in shape, and in C4 you can distinctly understand that it is less than 10 nanometers in size. So this is what we have observed the particle size. And then this on the left side, you can see the different forms of sheets that we have got during this process. It's just like a sheet, and you can just peel off and administer or apply to the skin. And when the cytotoxicity studies were done, we understood that 100 microliter per ml will be a good dilution for the studies. So we took up that and we went for the keratinocyte crash test, where we understood that MCP1, that is plain sheet, was having a better healing property. And after the plain sheet came the biosynthesized silver nanoparticles of Cantharis 30, and then direct Cantharis 30 was having a significant action. Then we went for animal study. In animal study, in the left side, you can see the images for the pre-study or the initial part of the study. And on the right side, you can see by the 21st day, what is the progress that we have received. In case of the group 1, the healing was present, little part of the wound which is not fully healed. But in case of 22nd, that is the silver nitrate nanoparticle group, there we have seen that the wound healing was very significant and very fast. In the 14th day, the wound has healed, but the hair growth has not reappeared. This is about the Cantharis mother tincture and biosynthesized Cantharis mother tincture. The healing is good, but still not fully healed in case of biosynthesized form, and hair growth was not fully back in case of biosynthesized form. This both are from Cantharis 30. MCP5 is Cantharis 30 itself, and MCP6 is biosynthesized Cantharis 30. Here you can see the wound is also healed and the hair regrowth is also present. And this is the last group, is the natural group. So what the overall observation what we made is, that is MCP2, and then comes the Cantharis mother tincture group, and then comes the other two groups, that is Cantharis 30 and Cantharis biosynthesized Cantharis 30. So these groups are having significant healing process, but then the hair regrowth was noticed only in case of our group. What problem we observed during this particular study is, from the in vitro study and in vivo study, the comparison was not matching. In case of in vitro study, the MCP1, that is plain sheet, was working well, but in case of in vivo study, the MCP1 was the last one to heal. So there was a contradictory response. Further studies has to be done to understand what exactly is the problem. But otherwise, to see Cantharis 30 and biosynthesized Cantharis 30 have given a significant healing in all the stages, by in vitro, in vivo, as well as stability of the particle. Everywhere it is having a consistent good result. So further studies, what we can do is, we can convert it into a self-adhesive plaster. And repeated dressings are difficult, so we may have to incorporate some pH indicators and make it like the indicators to understand when the dressing is needed to be changed, and those additions can be done on the further work. Thank you. Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am, for this interesting study. I may now call upon our chairperson, Dr. Todd.
Hi there. I had a little bit of trouble following because there was some computer breaking, but from what I was looking at, the natural control, if that's MP6, appeared to have fairly good healing from day 4 to day 21. But did you feel it was significantly different than the Cantharis 30C group?
So MCP6 was actually the marine-derived collagen peptide with biosynthesized silver nanoparticles of Cantharis 30. So that is actually the best among the groups that we have taken into consideration.
Okay, and which was the control? I couldn't figure that out. Was it MCP1 then?
MCP1, sir. MCP1 was the control.
And then the second question I had was, the silver nitrate nanoparticles, was that made from a homeopathic solution, or was it manufactured in some other way?
No, sir. Actually, when the silver nitrate solution, 0.01 millimolar silver nitrate solution, is subjected to react with mother tincture or 30th potency, we have observed that there is a reduction reaction which undergoes, and it is indicated by the color change. So after the color change has set in,
we have processed it, characterized it, and we have taken further into the study, sir.
So it's a dilute form of silver nitrate interacting with the Cantharis 30 or mother tincture.
Yes, sir.
Sorry.
Yes,
Okay.
sir.
Now I understand. That part was not perfectly clear, but otherwise interesting, very interesting work, and I hope it proves successful in the long term.
Thank you, sir.
Thank you, sir. Thank you, sir. Dr. Bhupinder Sharma, sir, please say a few words.
Yeah, it's a very interesting study. I'm quite happy. Only thing is, why Cantharis 30 was selected? Why not 6 or 1 or 3?
Clinically, we have I have seen internal administration of Cantharis 30 working better. So I went for Cantharis 30. And again, when we see the Avogadro number, 6 will again fall in less than Avogadro number. So it's like mother tincture and 6, we don't have much of difference. I wanted to have both the aspects, dynamic aspect as well as the physiological action. That's why I took from mother tincture and 30 to have a diverse understanding.
Thank you very much. Thanks. Great presentation. Thank you.
Thank you, sir. Thank you.
Thank you, sir and ma'am. Really, it was a great presentation and interesting too. I may call upon Dr. Deepika to take over the dais, please.
Thank you, Dr. Bharti. Now we may proceed ahead and call our next speaker, Dr. R. Valavan from India. He is going to present on the topic Nasodes and Sarcodes, and with the abstract title, Current Status of Expiry of Homeopathic Medicines in Bangladesh, Canada, Italy, and United Kingdom, a review. His abstract ID is 405. So welcome, Dr. Valavan.
Very good evening to all. Hope my presentation is visible.
Yes, it is visible, Dr. Valavan.
First of all, I thank the organizers for giving me this opportunity to present our work. This is actually the second part of our work on the status of expiry of homeopathic medicine as part of LMHI project, along with my colleague, Ms. Amarili Caesar from Brazil. First of all, it's a very debatable topic since long, even during Dr. Hahnemann's time, that whether homeopathic medicines should have expiry or not. And it is, we try to find out what is the status in different countries all over the world. And we worked on 4 different countries in the past, and we had published that in a paper. And then this is the second part where we have taken other 5 countries, different 5 countries, and we try to explore what is the regulatory status in those countries. So before going to that, let us see what is expiry. Expiry is defined in different ways based on the commodity, which commodity we are talking about. And if we take homeopathic, not general homeopathic medicines, but the pharmaceutical products, then we have certain specification that it is a point when a medicinal product doesn't meet its specification and it is deemed as ineffective, or it may be potentially harmful. So that is what we consider in pharmaceutical context. Depending on the product, it may be the expiry date may be fixed either after manufacture, certain period of time after the manufacture, or a period of time after dispensing, or a period of time after opening the container of the manufacturer. So in some part, in many part of the world, we can see that most of the eye drops have 1 month expiry after opening the container. There would be a general expiry of few years. Then apart from that, if one opens the container, then that bottle would expire, that product would expire in a month. So that is one example for the last one. And so basically the shelf life of the product is determined by either the breakdown of the active drug which is there inside, or maybe there will be an external contamination, risk of contamination for the product. If we compare the expiry followed in allopathy and homeopathy, in allopathy, it is basically the period of time where its pharmaceutical potency is more than 90%. When it reaches from 100, 95, then 90, then they consider that as a that product is expired. And in case of allopathy, the date of expiry usually marks when a drug stability, they conduct a stability study which has no longer been tested for safety and efficacy, and it fails to comply with its specification, be it its the pharmaceutical potency or other parameters, whatever is defined by the manufacturer. And so basically in allopathy, they consider the expiry, mostly it is related to the API, active pharmaceutical ingredient. If it is chloramphenicol, then the potency of the chloramphenicol has been tested. On the other hand, in homeopathy, ultra high dilutions are actually they are without any API. It contains only the dilution or the diluent, the medium, what we call as vehicle in homeopathy. So it could be either lactose, sucrose, or alcohol. And scientifically, the expiry or retest date is related to the both medicament and vehicle. In case of high potency, high dilutions, it is vehicle, and in case of low potency, when it works physiologically, that could be mother tincture or whatever the starting material. Until we have a new research which could reveal that the expiry of ultra high dilutions, we should relate only to the vehicle mostly in case of ultra high dilutions. And as our previous work has shown that when we have analyzed and compared 4 countries, Brazil, Germany, India, and the United States, about the regulatory status of expiry, most of the countries have 5 years expiry, except most of the countries in the sense that starting from Brazil, Germany, and India. But the United States doesn't have any expiry, but at the same time, HPUS, Homeopathic Pharmacopoeia of United States, encourages the manufacturers to have expiry period on the products. And India has a 5 years expiry maximum, but for dilutions and back potencies, it is not required. And Germany is 5 years expiry maximum, and Brazil also has 5 years expiry, but at the same time, it can be extended based on the microbiological or stability studies. And also in case of stock solution, retest date can be applied for extending the expiry date. We have chosen 5 countries by random selection: Bangladesh, Canada, Italy, and the Netherlands, and the United Kingdom. And if you take Bangladesh, it has a very varied expiry period for different products of homeopathy. Mother tinctures and the homeopathic formulations, the combinations have 5 years expiry. Dilutions have the very long expiry period of 18 years. And in case of biochemics, 3 years expiry, but at the same time, it can be extended based on the stability study of the manufacturer or importer. If a manufacturer or importer provides a stability study for their biochemic products, then the expiry period can be extended only for that particular manufacturer, not for all manufacturers. And this is the very new regulation. It came on 27th of October 2021. And if you look at Canada, it's a 5 years expiry. It's a flat 5 years expiry, but at the same time, the country follows ICH guidelines for stability study. And the documents show that, especially in case of products which contain less than 50% of alcohol, there should be a special focus on the microbiological contamination in the product. And in Italy, mother tinctures have mostly 5 years expiry, and dilutions also have, but that may vary. And in case of formulation, it's again 5 years expiry. In case of biochemics, it's 3 years expiry. And if you see the mother tinctures, 95 mother tinctures fall within the category of 5 years expiry, and the rest may be less than 5 years expiry. And the dilutions have maximum of 5 years expiry, but it may, depending upon the dosage form, either pills or tablet, it may vary. And also experts suggest that the formulation should bear 5 years expiry, provided that the stability study should be assessed by the manufacturer. And the Netherlands has a very low expiry period, very short expiry period. And mother tinctures, dilutions have 2 years expiry, but at the same time, here the difference is most of the countries follow the expiry from the date of manufacture. But in Netherlands, it is the expiry dates would start from the date of filling or adding the product into the usage container. So if a product is manufactured 2 years ago, but it is filled today, so the expiry would start, 2 years expiry would start from today. But in case of stock solutions, it can be extended for another 5 years. after a retest or re-examination. And the United Kingdom has a flat 5 years expiry, but at the same time, it follows mostly the expiry shelf life study, which is followed by European Union. And the dilution stock should be assigned of the same expiry of the original stock, the original back potency. And if we just ponder about whether we need really expiry for homeopathic products, we would say that yes, it is required, but at the same time, we should consider the physicochemical properties of the ultra high dilutions, because ultra high dilutions have no physicochemical property that is only related to the vehicle. But in case of mother tincture or low potencies would have the physicochemical property of the starting material. So that aspect should be considered. And stability of mother tincture, generally it is 5 years, but there are many studies which show that mother tinctures are stable even for 10 years. And if we look at the ultra high dilutions, there are many studies, as I'm showing here, that they show that they have longer shelf life than what generally followed, 5 years or 2 years, 3 years. And storage conditions and environmental influence also have some influence on the expiry or shelf life of the product. So if a product is stored in a GMP laboratory, then it may have the longer shelf life. So that should be considered before fixing the expiry. And also we should consider about the vehicles, whether how it would be, how stable it would be. And as per Lenger et al., they found that sucrose globules are more stable than the ethanolic solutions. And another study, another references suggest that ethanol has almost indefinite shelf life if it is stored in a proper container. And our conclusion is that based on this small work, except Bangladesh, all other countries are following 5 years expiry maximum. And Bangladesh has 3, 5, and 18 years of expiry period. And assigning expiry date for ultra high dilutions without a valid reason is a concern for manufacturers, especially because there are many rare medicines which do not have, which cannot be again and again prepared. And there are many factors we need to consider for assigning expiry date, like raw material, storage condition, potency level, and expiry based on the scientific stability studies of each medicinal product is actually the recommended one, and worldwide it is being followed. Regulatory bodies have started following these. I would like to acknowledge people who have supported for this information, this work, that Andre Saine from Canada, Dan Khrushchev from the Netherlands, Fahim Al Amin from Bangladesh, Lee R. Kane from UK, and Renata from Italy. Thank you so much.
Thank you, Dr. Rathod. It's indeed been a very interesting study. And I would like to request our esteemed chairs to please ask some questions from him.
So I'll start if that's okay. This is a subject that's very near and dear to my heart, as the U.S. is, the HPCUS is currently in active conversations with FDA on the topic. There are some real troubling areas of this conversation. One is, how do you test a substance? What is the active ingredient? You know, there is no known active ingredient. The active ingredient is the substance, right? It's the totality of everything in there. So how do you know if there's stability? Because what do you test? Do you test every single molecule that's in a plant, for example? So that creates its own problems. Then you have the issue of things that go beyond limit of detection using TLC or other methods. How do you measure if something is degrading in solution in these ultra high dilutions? We don't have a way to do that. Then you have the third issue, which is measurement of the active property of the medicine. Does it work? So when you use medicine, nobody's ever studied it. You know, no one's ever studied a medicine at 1 year, 2 years, 3 years, 4 years, 5 years to see if it's more effective or less effective over time. And then finally, the issue that really tends to hit home with the FDA and other regulators is container closure systems, where silica and other compounds are leached into the homeopathic product, therefore changing its character so that it's not the same drug that you started with. And then the last issue, which is really important, is some of the substances no longer exist. So carcinosinum, we have no carcinosinum. We have the original substance from 80 or 100 years ago that's been used for all this time and still seems to work, but we don't have any current ingredients, no APIs any longer. Some things are now restricted. Corallium rubrum, for example, is a endangered species, so you can't get corallium rubrum. And other issues similar. Some sources of the springs have actually dried up, so we can't get that compound anymore. So we face these issues in the pharmacopoeia constantly, and it's a good thing to research. It unfortunately is a can of worms, I think. So thank you for your work on this area.
Thank you, Dr. Hoover.
Thank you, Dr. Todd, for your valuable feedback. May I call upon Dr. Binder Sharma, sir, to ask his questions?
Yeah, very interesting study. And being in Canada, we were looking for this type of study earlier while I was making the policies for the Council of Homeopaths of Ontario. So, a few questions. The ideal percentage of alcohol, in Canada, they use 80% for dilutions, and boron uses 90%, but they also use 13%. So I think the expiry date changes if it is 13% and in dilutions, or if it is 90%, or it is 80%. So what are your views about that?
My
to
views
include
are, yeah, there should be uniformity in the manufacturing. And yes, of course, if it is 90%, yes, the stability definitely it would be very high. And as I have shown that if it is 90%, then there could be indefinite stability as we follow in India. But if it is 30%, then it is the rest of 87% is just a water. It is an aqueous solution, so it has I would say that it has short shelf life, so it should be considered.
Yeah, so very happy about your study, and we want to share your study, and also keep on doing that. Thank you.
Sure, sir. Sure. Thank you so much.
Thank you. Bye.
Thank you, Dr. Dr. Bhupender, for your encouraging words. Thank you, Dr. Valvan. Now, as we are about to conclude our session, I would request our esteemed chairs to just summarize the entire presentation. Dr. Todd, Dr. Bhupender, kindly summarize the presentation of the articles and the abstracts we just had in this session.
Okay, I'll take a stab.
Yep.
So, all of these topics actually are very important with regard to homeopathy. The subjects initially covered were antibiotic resistance and, diseases where conventional medicine is failing. So, Japanese encephalitis, the tuberculosis epidemic, the issues with antibiotic resistance and diseases. All of these are issues and malaria, all of these are issues the conventional medicine is not working very well for. So they are terrific opportunities for homeopathy, terrific possibilities for the future of homeopathy. And it's, in my opinion, where research dollars should be spent, where we should be focusing. I also really enjoyed the talk on this potential product for burns. And I think commercially something like that could be really very valuable. I mean, I know you never know when one of these projects is going to take off, but something like this could really change how homeopathy is received around the world if it's effective. I can't stress the two areas that are closest to me, the proving the HPT work that was done on the strychnine product. More work needs to be done in provings. And I played a pretty big role in developing proving guidelines, and hopefully those are in the future will be harmonized with the HPI and the LMHI and HPUS, as well as the European Commission. So hopefully the HPI probably already pretty consistent, but in the future that will be looked at also. And then finally, this expiry dating, it's a very difficult subject, and much more research is needed to be done. And I'm not sure there will be a solution. I think the conventional medicine folks will do what they do, the regulatory, but the more you can push back on it, especially in a place like India, where homeopathy has a strong foothold and may be able to better define how the rules apply to them, it's a worthwhile effort. So thanks everybody, wonderful presentations.
Thank you, Dr. Top. Thank you for your viable feedback. Over to Dr. Bhupinder sir now.
Yeah, extremely happy about giving these two topics of role of homeopathy in infectious diseases and antibiotic resistance. And this is a very hot topic, especially when WHO has shown its concerns about this thing. And AAH has taken up, the petition also. And very nice to hear from the presenters. The next theme was the innovation in pharmaceuticals, and that is also very interesting, things to discuss. My thanks to the organizers and Dr. Deepika and others.
Bharti.
For, yeah.
Thank you so very much for our
Everybody,
esteemed
yeah.
chairs. They have been quite motivating.
Thank you.
And we had a very captivating and fascinating session. Thank you so very much, our chairs and our speakers. Thank you so much.
Thank you.
That concludes
Thanks
the
so much.
session.
Thank you.
Thank you.
Thanks.
So I'd like to take this opportunity to thank our chairpersons, our speakers who were here throughout the session. I would also like to thank Dr. Bharti and Dr. Deepika to moderate the session, and also our session coordinators, Gauri and Srishti, for staying back with us. Thank you so much. Thank you for being here. I'm your MC Himay, signing off for this session. Thank you very much.
Thank you. Bye-bye.
All right, so quickly moving ahead to our next session, I think we have some attendees. We have already Dr. Sujata. We have Dr. Sujata Goda with us. We have just promoted her. So upcoming session, the theme is case reports, observational, paradigmatic, and randomized controlled trials. I would just like to acknowledge our moderators if they are present with us. Do we have Dr. Shaili Arora and Dr. Nirmal Yadav? Are you with us? All right, not yet.
Sorry to interrupt, Himay.
Yes, ma'am.
You're talking about the next session, right?
Yes, madam.
So maybe leave now. Or maybe we can join later.
Yes, you can do that. If you would like to stay back, you're more than welcome.
Yeah, thank you. Definitely we'll join later.
Thank you for being with us over here. Thank you for the help, ma'am. Thank you very much.
Thank you. Thank you, Himay. You did a wonderful job.
Thank you so much, ma'am. Thank you.